Hello, I'm Michael Virata, an assistant professor of clinical medicine at Yale, and I've been asked to provide this audience with information about the approach to HIV testing for the general population. For this discussion, we will touch on the current CDC testing guidelines, why testing is important, the current testing algorithm with a fourth-generation combination assay, laboratory test results, and the frequency of HIV testing. When HIV was becoming more of a chronic illness as a result of the use of highly active antiretroviral therapies in the United States, the CDC in 2006 came out with new guidelines that outlined the approach to HIV testing in all healthcare settings. The two major points of the guidelines were that HIV screening should be recommended for all patients after being notified that testing would be performed unless they declined the test, also known as opt-out screening. The second point was that only general consent was necessary, and to replace the requirement for written consent from a patient. Many providers are unaware of changes in a Connecticut statute that now basically reflects the CDC recommendations. Briefly summarized, it eliminates both the need for a separate consent and the need for formal, extensive pre-test counseling. Even with new guidelines in place, HIV testing is well below expectations. Published reports show that less than 10% of inpatients and outpatients were offered any screening. In outpatient settings, most HIV testing is only considered either when the patient's demographics and behaviors are recognized as strong risks for acquiring HIV infection or as a requirement for screening pregnant women. Prenatal screening is the most successful HIV testing program in the country and has virtually eliminated new perinatal infections. In Connecticut, we have not seen a positive case in nearly 20 years. In an effort to expand testing, the CDC provided funds that could be used for increased testing in specific areas of high HIV prevalence and among certain vulnerable populations most affected by the epidemic. These are minority MSMs, or men who have sex with men, transgender females, and heterosexual women of color. This type of initiative led to improvements in both the number of individuals tested as well as a significant increase in the discovery of new cases each year. In the US, about 1 in 7 persons living with HIV are unaware of their infection and do not manifest with any symptoms of the disease. Younger adults with undiagnosed HIV are less likely to be aware of their status. In 2012, it was estimated that nearly half of the populations eligible for HIV screening had never been tested. Increasing awareness of one's status can lead to better engagement in healthcare and help to prevent the spread of HIV. People who remain undiagnosed and therefore not in treatment are likely to have high levels of HIV viremia and can easily transmit HIV to others via sexual contact or sharing of contaminated drug equipment. Based on national surveillance data, it is estimated that nearly a quarter of all new infections are the result of risk exposures from the 13% of the population that remain undiagnosed. People diagnosed and living with HIV/AIDS who are not engaged in healthcare also contribute to a substantial number of new infections each year. For the approach to HIV testing, the use of the opt-out method has been the recommendation from public health experts. This approach makes HIV testing more routine rather than targeted, but also provides the patient with a verbal option to decline testing. A few simple questions can be used to start the conversation, such as, have you ever been tested for HIV? When was your last HIV test? And what was the result of your last HIV test? If the patient has never been tested, it would be a good idea to perform a risk assessment. Risk assessments should be done with a non-judgmental approach. These are sensitive areas of a patient's personal life that they may not be willing to disclose to just any clinician. For HIV testing, the focus of the questions may be on gender identity, sexual orientation, sexual histories and behaviors, the use of prophylaxis or barrier protection, and substance use. Some individuals do not realize that they are putting themselves at risk. This can be done in the context of obtaining routine screening for other conditions. Ask about any history of a sexually transmitted infection and ongoing or past substance use, particularly via injections. Once the patient accepts and provides verbal consent for testing, they must undergo a blood draw. That sample will be sent to the laboratory for testing. On this slide are two procedures for HIV testing that can be performed in a laboratory. One device is used to detect HIV RNA or a viral load. It is an HIV-1 specific nucleic acid amplification test, or NAT. This is a quantitative assay. It is a test of high complexity. It is the most sensitive test available for diagnostic use and capable of detecting HIV during an acute infection. The other procedure is the antigen-antibody combination assay, currently in its 4th generation. This is a moderately complex test that is recommended for use in initial testing. It can be a manual point-of-care test or a fully automated platform. This test can detect HIV antigen or antibody. Before going over the new testing algorithm and results, I wanted to review a brief timeline that helps to illustrate what may appear in the blood of a patient from the initial time point of an HIV infection. Viral RNA can be detected by NAT as the first evidence of virus in plasma. This occurs around 10 days from the time of infection. The period before RNA can be detected is called the eclipse period. A combination or 4th generation test looks for both HIV antigens and antibodies. Antigens are foreign substances that cause the immune system to activate. The antigen is part of the virus itself and is present during acute HIV infection. These can be detected as early as 14 days. It takes time for the body to produce enough HIV antibodies for a test to show that a person has HIV. Antibody to HIV can be found in whole blood, plasma or serum, and oral fluid. The soonest an antibody test will detect infection is now 3 weeks. The time to detection from the initial infection is known as the seroconversion window period. The current test is a 4th generation assay. Earlier generations of testing kits detected antibodies 21 days or later. With any type of antibody test that has a positive result, a confirmatory test will be needed. Next, I would like to review the newest testing algorithm using the 4th generation combination test. It has created some confusion, mostly around trying to interpret the results. It is a departure from the use of the Western blot that was the traditional method to confirm any HIV infection. This new testing algorithm consists of 2 steps: an initial immunoassay that detects either HIV-1 or HIV-2 antigen and/or antibody. If the immunoassay test is negative, there is no HIV infection. If it is positive, the next process would be a differentiation immunoassay. This is used to detect specific antibodies to either HIV-1 or HIV-2, both or neither. If antibodies to HIV-1 are positive, then it establishes an HIV-1 infection. In very rare instances, both antibodies to HIV-1 and 2 will be positive. If both antibody tests are negative, this will be designated as an indeterminate test, requiring one final procedure consisting of the HIV-1 specific NAT using the RNA reverse transcriptase PCR platform. For an acute HIV infection, we would expect to find a very high HIV viral load. If negative, the person does not have HIV-1 infection, and the initial screening test could have been a false positive. This is what a test result may look like for someone with an HIV infection. The HIV antigen antibody test is positive, but the differentiation assay for HIV-1 or 2 antibodies is still negative, thus the indeterminate interpretation. With the addition of the NAT or PCR testing, we now know that this patient's test result is compatible with acute HIV infection. The HIV viral load is extremely high. If the viral load was low in the range of a few thousand copies, then the testing protocol should be repeated with the same sample. When the NAT test is negative, then this may be considered as a false positive screening test. False positive test results may be secondary to the following conditions: pregnancy, the presence of rheumatoid factor, syphilis, hypergammaglobulinemia, or autoimmune hepatitis. The most common scenario in our practice is a multi-gravid woman who's being tested as part of prenatal screening. As to the frequency of testing, HIV screening should occur at least once in the lifetime of all individuals in any healthcare setting. Patients with behaviors that put them at risk for acquiring HIV should be tested more frequently and can be done every few months or after any known exposure to HIV. Then, at least annually during regular primary care visits. If an exposure occurred with a known HIV positive person not on treatment or with a detectable viral load, then the patient should be tested immediately and start post-exposure prophylaxis for 28 days if the baseline test is negative. Then, the patient should be retested in 4 to 6 weeks to make sure the patient did not seroconvert. In summary, HIV testing should become part of routine screening for the general primary care of all individuals. A clinician can determine the need to test more frequently based on a risk assessment evaluation by asking about certain behaviors and potential exposures. Use only FDA-approved testing algorithms and equipment. With more screening, we can help to diagnose those individuals who are unaware of their HIV status and link them into care immediately so that they can receive the treatment that they need to control the infection and live a normal and safe life. Our hope is that this will lead to the end of the HIV epidemic. Thank you for taking the time to listen to my discussion on HIV testing.